Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Sandoz.
This program is presented by Medscape Education Global.
Hello, I'm Heinz Windel, Professor of Neurology and Head of the Department of Neurology and Neurophysiology Medical Center at the University of Freiburg, South in Germany. Welcome to this program titled JC Virus Testing 101, what you need to know about JC virus testing in multiple sclerosis care. I'm here today with Wallace Brownlee, who is a consultant neurologist at clinical lead at the MS Service, National Hospital for Neurology and Neurosurgery in London, UK. Welcome, Wallace.
Thanks, Heinz. Great to be here.
Why do we need to understand JC virus testing? So, JC virus status helps us to stratify the risk for progressive multifocal leukoencephalopathy among our patients with MS who are on certain immune therapies, primarily natalizumab. We know it can occur in other disease-modifying therapies, but which are much lesser degree. And with all the other therapies, we cannot stratify for it. PML is a rare opportunistic infection, as you know. We've seen it in earlier years more rarely, but with the advent of specific immune therapies, we're now very vigilant and aware of that. To set monitoring schedules to test for JC virus antibodies in patient is essential because after a certain time period, it does matter what your JC antibody status is, and also how high the status is means the index of how the antibody that you're discovering or measuring, how high the antibody titers are. So Wallace, we've been using natalizumab for quite some years, and we've been testing for JC antibodies. What can you tell us about that?
So natalizumab remains a commonly used drug for the management of patients with multiple sclerosis. But of course, because we have to be concerned about this possible risk of progressive multifocal leukoencephalopathy, JCV testing is required to safely prescribe natalizumab. And I guess a change that's happened in the last year or two has been the availability of a natalizumab biosimilar. And along with that has come a new test to test for JCV antibody status and the JCV antibody index, what's called the immunowell assay.
Let's briefly remind our audience how this is tested and what's the technology behind. So it's called ELISA. I guess most of us might remember from some courses what that is, but we'll briefly show how an ELISA works.
So the ELISA technique is a widely used technique in diagnostics and marker detection. Examples include neurofilament light chain, detecting antibodies against infectious diseases such as hepatitis. They are also used to detect and measure anti-JC virus antibodies in human serum or plasma. And to detect anti-JC virus, we're using a two-step process. So let's take a simple look at how they work. Target antigens, the JC virus-like particles, pre-coat the bottom of a microwell plate and are immobilized. Then wells are washed with a wash buffer to remove any unbound substances. This occurs between each main step. A blocker is added. And then serum or plasma samples from patients are added directly to the wells. So what happens then? If anti-JC virus antibodies are present, they bind to the antigens on the bottom of the wells. Then they are incubated with a secondary antibody in a solution. And this anti-human immunoglobulin G antibody is designed to bind the antibody in the wells. And this is coupled with an enzyme. A colorless substrate is added, and if antibodies are present that have bound, the enzymes cause a color reaction. A spectral photometer is used to interpret the optical density of this color change and converts it into an index value corresponding to positive, negative, or indeterminate. So if the result is indeterminate, the JC virus ELISA tests include a second confirmatory step. And a confirmation assay is performed on the same sample. And then again, a positive or a negative result is determined. And then this report results in the index value, which is nothing else than a quantitative correlate to the intensity of the color reaction, is then provided to the clinicians. So all of those tests have subtle differences, starting with the underlying antigen or with the washing procedures and so forth. But what is essential, and this is true for any ELISA test, is you have different sensitivities and specificities. And how does this work? So if you look on this 4-quadrant visualization, you see that the sensitivity will tell you how likely a test will detect if a result is truly positive. A high sensitivity means there are fewer missed cases, and the test can detect even extremely low levels of JC virus antibodies. So this is what you would like to have, a reaction to even minimal amounts to JC virus antibodies. On the other hand, the trade-off is specificity. And that means that the ability of the test is as best as it can be to correctly identify true negatives. So a high specificity minimizes then false positive rates, which you might have with a high sensitivity, but it could label patients as being at risk when they are not. In turn, positive predictive value indicates the likelihood that a person with a positive test results actually really has anti-JC virus antibodies. And the negative predictive value means that they do not have them in case they really do not have them. So that means you have a true negative and a true positive as opposed to a false negative or a false positive result. This is the principles of ELISA, and these individual assay properties can then lead to different cutoffs or index values and different results between different JC virus assays.
So this is how the assay works. So what can you tell us about the specificities and peculiarities about the JC virus cutoff ELISA values and the index?
Sure. So the JCV antibody tests, like other tests, for example, for viruses, report initially as being positive or negative. And of course, like all laboratory tests, there's a predefined threshold that indicates whether the test is positive or not. And so for both of the available JCV tests, the Stratify JCV and the ImmunoWell assay, there is a negative cutoff level that defines what a negative test and a level also that defines what a positive test is. Now, over and above that, studies from over 10 years ago identified that patients at risk or at the highest risk of progressive multifocal leukoencephalopathy carried higher JCV antibody levels. And so along with either a positive or negative test, we also get an index value reported that indicates whether the person is at a low, intermediate, or potentially high risk for PML. And those values for the index do differ between the Stratify and the ImmunoWell tests.
So Stratify is the old one. We basically are used to the, let's say, thresholds and the reported assays. The ImmunoWell is the new one with a new biosimilar. And the reported thresholds, what do they mean? So if you're positive, are you then necessarily at a higher risk, or is that also to be subcategorized?
So within patients who are positive or negative, we get an additional reading from the JCV antibody index. And people, for example, with an index value of over 1.5 in the, let's say, traditional or established stratified JCV tests are at highest risk for the development of progressive multifocal leukoencephalopathy.
Yeah. And if they're less than 0.9, you would say they're basically like they would be negative, despite the fact they are ELISA positive.
These patients are certainly at lower risk for this complication, that's right.
There is one thing which now puzzles a lot of, let's say, users of the tests, is how those tests really correlate. I mean, they're basically the same technology, but they are two different tests in a way. And what usually is done is to correlate those tests, and the correlation, when you look roughly, looks pretty impressively good. But if you look at individual values, there might be differences. And that is exactly how those two tests would be compared to each other. There is measures like a test positivity, test negative, whether they are truly positive or whether they are false positive. So this is like the quadrant analysis, and this is what you overlay. And this is also what has been done by the regulators and how it has been described. So maybe to explain our audience, why are there differences?
Well, I think that with any laboratory test, if you're testing the same thing in two different laboratories or with two different available tests, whether it's even something very basic like hematology or biochemistry, that if you test the same sample with different tests, you may obtain varying results. And because of these differences in the cutoff values between the Stratify and the ImmunoWell assays, we have seen that some patients are coming back with different results on these tests.
I recall from the early days of the natalizumab Stratify test, when they changed from Stratify 1 to Stratify 2, this also made changes in the thresholds in a way. So patients all of a sudden, because the test became more sensitive, became positive, which is not the same as they having immediately a completely different risk category, because it depends on the level of positivity then. Would you agree?
That's right. And I think that when you apply a different diagnostic test with different cutoff values, you may get different results. It doesn't mean that person's risk has changed particularly. It just means we've got different results available from different tests.
So maybe we explain a little bit how the wording of the regulatory documents with regard to the ImmunoWell assay really reads. So how have they compared it and how do they explain it?
So what they did when they looked at the two tests for the purposes of the regulators was look particularly at the sensitivity of the tests and the negative predictive value, because these are what we're kind of immediately most interested in, right, as clinicians. If we're thinking about using natalizumab as a possible treatment option for MS, we want to determine, is the person JCV positive or JCV negative, to help inform those treatment decisions. But I guess what was seen early on is that there is a difference in the specificity, and the specificity was different for the ImmunoWell test compared to the Stratify test as the so-called reference standard.
Yeah, absolutely. And this is exactly what now happens or might happen in clinical practice, that a patient tested with a new test all of a sudden then becomes positive despite being with the previous testing negative, which can be explained technically and not necessarily biologically.
That's right. And a number of groups have now reported their experience with the implementation of the new ImmunoWell test. So, for example, a multi-centre study from the United Kingdom, where a proportion of patients who previously had tested JCV negative on the stratified test had, when tested using ImmunoWell, came back with a low positive value on that test. And there was a further study from France that looked at about 259 patients. And of the patients who were positive on Stratify, roughly 23%, actually 61% were positive on the ImmunoWell. And I think that as neurologists, we're faced with managing these patients who might have discrepant results on these two different tests for assessing JCV status and JCV antibody levels.
Yeah, right. What I found extremely interesting is a, let's say, guideline or recommendation piece that UK released recently, and I guess you were part of it. Can you explain what the key messages out of this written statement are?
Sure. Well, a group of us got together from the UK to try and bring together some guidance for how neurologists might approach these situations which we're now confronted in clinical practice. And these were consensus guidelines from MS specialists from across the UK. And really what we agreed on is that if you've got a JCV negative patient on both tests, then you can be happy that the person is JCV negative. But I think similarly, if you've got a person who's JCV positive and a high index value on both tests, that can be quite concordant. But the difficulty is there's a group of people who may have tested JCV negative on Stratify, who when you apply the ImmunoWell have a JCV positive at a very low index level. And it's unlikely that this reflects seroconversion from JCV negative to JCV positive. This is when we've applied a more sensitive test for the detection of JC virus, we've come back with positive tests. I think that in the guidance we've offered some recommendations for neurologists who are encountering these patients to think about the situation, to think about whether any steps are required for risk mitigation for PML, and how you might approach further follow-up and testing.
Very helpful, absolutely. I guess we've quite nicely tried to explain how the assay works. There's two different assays. They are in many patients concordant, but in some they are not. But that doesn't mean that the biology of the patient has necessarily changed. It's a technical difference, and people have to be simply aware of that. There is now a guidance piece by the UK colleagues helping how you deal with this, and try to navigate yourself and monitor patients throughout and with the respective monitoring schedules and stratification tools that we have in addition to the assay, which is MRI clinical visit. Let me conclude here. We've explained that the underlying technology, how you assess the exposition of an individual with regard to reactivity towards JC virus, is an ELISA. ELISA can be positive, negative, but it has also a so-called value, which is called the JC antibody index. And depending on the index, you would stratify your patient in different categories of risk, very low, intermediate, and high. With the advent of the natalizumab biosimilar, there is an additional second test. It's called ImmunoWell. They work essentially the same way, but it's relevant to acknowledge that the specific assays are linked to specific products, also by a regulatory approval process. So you need to know, and this is the goal of this educational piece here, is how to interpret the results and to discuss them then with your patients. And the adoption into clinical reality simply requires this knowledge. Wallace, thanks very much for the great discussion. Thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.